Hi, I'm Clara Badia, a cardiologist at Vallebron Hospital of Barcelona, presenting a case of familial non-syndromic aortopathy. This is a 56-year-old woman as our patient who has no known cardiovascular risk factors and no prior cardiac history. And initially, there were no family histories that suggested heart disease or aortopathy. Who was admitted in August 2008 to another center due to chest pain that required an aortic angiotomography, where a type B aortic dissection was observed, as you can see here in the CT images. The CT scan also indicated that the aortic root and ascending aorta were not dilated. The proximal arch just before the beginning of the dissection measured 39 millimeters, and at the distal arch, a large entry tear that originated the aortic dissection that extended to both iliac arteries, with involvement of the left subclavian artery ostium, which was dissected but remained patent, and some visceral trunks that originated from the true lumen and were well perfused. The maximum aortic diameter measured 63 to 64 millimeters. Additionally, a small aneurysm was noted in the hypogastric artery region. Upon admission, the patient achieved effective pain and blood pressure management. Several CTs were performed during the hospitalization, revealing no increase in diameters or new periaortic complications. And the case was evaluated with the vascular surgery team. It was decided that, given that the patient had shown good clinical progress, there were no complications and the surgical approach was complicated, thus it was decided to discharge her and assess outpatient treatment options. In this particular case, atenolol was initiated with good blood pressure control and tolerance, and an outpatient follow-up was started in our center's aortic disease clinic, where she was referred following the acute event. During visits to the aortic disease unit, an initial family tree was created, showing no relevant history that could suggest a priori of family orthopathy. A thorough physical examination was performed. Non-physical signs indicating Marfan syndrome, Loeys-Dietz syndrome, or vascular Ehlers-Danlos syndrome. At that time, given the circumstances, it was different from today, meaning there were no aortic panels at hand, as is the case today. Thus, genetic testing was performed based on clinical suspicion, which was not specific at that time. It was decided to postpone genetic testing and reevaluate it later, based on the clinical findings that would emerge. What was done was to evaluate surgical options, which were assessed by the Aortic Disease Committee, composed by cardiac doctors, vascular surgeons, and cardiac surgeons. They decided to carry out elective surgery in 2 phases. First, they would perform an aortobic carotid bypass, since due to the anatomy of the dissection, placing a stent, which would seal the entry point, posed a risk to the left carotid's perfusion, so an aortobic carotid bypass was necessary at first. And once the perfusion of the supraaortic trunks was protected, endovascular treatment would be performed using a stent. Initially, the patient was hesitant about surgery, which caused the procedure to take longer. In January 2011, the patient was admitted for elective surgery to perform an aortobic carotid bypass with the technique that we can see described here. The vascular surgeons were surprised by the significant fragility of the aortic tissue that the patient presented, and the fragility was so pronounced that during the surgery, the patient had a serious complication, a retrograde type A aortic dissection, which forced the team to perform an emergency surgery to replace the ascending aorta with a 30mm HemoShield prosthesis, and to reattach the bypass that connected the ascending aorta to the brachiocephalic trunk and left carotid artery at that time, to attach this bypass to the tube. The patient had a very complex post-operative period, which was very long, with multiple infections, including a respiratory infection and a very slow recovery, and a significant critical illness myopathy with considerable fragility. Quite significant. Therefore, given this situation of extreme fragility, it was decided to discharge and reassess the approach to the descending thoracic aorta on an outpatient basis. Once the patient had recovered functionally, therefore, we resumed the monitoring of consultations regarding aortic disease. During one of the follow-up visits, the patient reported that in her nephew's son, a 38-year-old had been hospitalized for a type B aortic dissection. This necessitated a re-evaluation of the case, and considering this new information, it was suggested to perform a genetic study, already at that time through a panel, and a study of relatives. The aortic pathology panel revealed a variant in ACTA2, identified as a missense variant, which was then deemed probably pathogenic. As you know, ACTA2 is a gene on chromosome 10 that encodes the actin gene expressed in smooth muscle and regulates its contractility. Variants in this gene have been described to lead to thoracic aortopathy, among others, which would be the case of our patient. In light of these findings, both clinical and genetic studies were conducted on the various relatives we had access to, finally able to create this family tree that you can see here. Then, the patient, our index case, who is the patient marked with the arrow, who was our patient, a variant carrier and had shown dissection, had a history of sudden death in the father at 67 years old. The father must have been an obligatory carrier of the variant since his sister, that is, the maternal aunt of the patient, was a carrier of the variant, and the nephew of the patient, who had also presented with type B aortic dissection, was also a carrier of the variant he inherited from his father. The genetic study was finalized, revealing that 2 of the patient's daughters were also carriers, along with the patient's sister and 1 niece, and also, a more distant family member. Thus, close monitoring of all family members carrying the variant was also initiated through echocardiographies, aortic angioct, and also the abdominal aorta, and also intracranial angioct to rule out the development of aneurysms in different locations. Thus, it was concluded that this was a familial non-syndromic aortopathy due to ACTA2. Going back a bit to the case regarding our patient, an outpatient follow-up was conducted very closely with control angio-CT, and what was observed was a rapid progression of the diameters at the level of the descending thoracic aorta, with an increase of several millimeters over just 2 years. In February 2010, it measured 66 millimeters, and by February 2011, it was 71 millimeters. A significant enlargement. The patient had adequately recovered from the surgery, and it was decided, based on the prior surgery, to proceed with the approach to the descending thoracic aorta. And finally, it was discussed again in the committee, taking into account the context of familial aortopathy in this case, and the notable aortic fragility seen in the previous surgery. It was determined to rule out endovascular treatment, and ultimately, in 2012, an open surgery for replacement of the thoracoabdominal aorta with reimplantation of visceral branches was performed, leaving a residual dissection at the level of the abdominal aorta, which has been carefully followed up on an outpatient basis without any signs of growth, so no surgical intervention was necessary. In short, this case involves a woman suffering from a familial non-syndromic aortopathy, which has a probable pathogenic variant in the ACTA2 gene, who first showed symptoms in August 2008 as a type B aortic dissection. They performed the first surgery to create an aortobicarotid bypass, but it resulted in a complication of a retrograde type A aortic dissection, which required an emergency surgery to replace the ascending aorta urgently and reattach the bypass to the tube. And because of the increasing diameters after she recovered from the fragile condition post-first surgery, an open surgery was performed to replace the thoraco-abdominal aorta with reimplantation of bilateral vessels. In 20 years of follow-up, stability has been observed in both the diameters of the aortic root and the native abdominal aorta, and no intracranial aneurysms or aneurysms in other areas have been detected. Thank you for your attention.